used in updating his legislature, or her legislature actually, in July of this past year. So these are recent slides, and I have, attributed the source, so these are not my slides or our slides. So I just want you to see a few of these, and I know I put it in your packet. I sent it to you, so you'll have that anyways. But the Kansas story is a really good story. It started off I would say it wasn't a good start. It was like Iowa. There were a lot of complaints, especially in the DD area, the developmental disability area. But they've managed to be able to work with that population and try to help them understand, and they were then put savings into the wait list, and they've also done some really good work on the long-term care area. So looking at the slide, the secretary's slide, Kansas Medicaid and CHIP has used managed care models in children's and families since the 90s. That's your lower cost model. That's not your ABD. Kansas historically was not outcome oriented. Okay, and I want to focus on that for a minute. If you move to a value-based purchasing system in patient-centered medical home or managed care, you move to more value-oriented cost of care. So that's where you are today is more on compliance. You're not on measuring and working on outcomes to make sure you're performance-based. And if you move down that road, that's when you're going to start seeing savings and better quality. But the risk has to shift as well. And that doesn't mean always loss. It means gain if you really do a good job. And that's the whole managed care, PCMH world out there now. So that's what Kansas saw, and that's why they moved into this area. They developed CanCare, a coordinated managed care program. The centerpiece was integrating managed long-term services and supports with physical and behavioral health. After a one-year delay of the inclusion of managed long-term supports for members with DD, they started to include DD, the developmentally disabled. That was the last piece. And again, that was the tough piece. I remember there were marches on the State House. It was a difficult rollout. But the governor and his staff kept assuring the community they're going to do the best they can, and they apparently have. You can see in the next slide who's eligible, and you can see the children, most of the population. It's all the populations that we would call high cost here as well. Developmental disability, elder, and also behavioral health is in there. So in year calendar 12, you had 101,000. By calendar 14, 104,000. So more than 100,000 beneficiaries qualify in that state as seniors or people with disabilities. Not that far off, but that's a pretty large sum of your age, blind, and disabled population that's now in managed care. Now, this is an important slide, number 40. This is the timeline. So you ask about timelines. We had said 18 months to 2 years. You can see there's a lot that has to happen here before you roll out a managed care, which is why we didn't target savings until the outer years, looking at 17, 18, when you start to really absorb the savings in your budget. They started the summer of 2011. You can see November, they announced the RFP release, and then they don't go live till 2013. And that was not in the DD area. That was everything but the DD. That was the second phase. And that went live in February of 2014. And today, it's all live, all in managed care. It runs concurrently with their Section 1115 demonstration waiver, or actually not the demonstration, the 1915C waivers. CanCare's predicted 2013 CMS guidance. Many of the key elements have been addressed and reflected in the model. Readiness reviews, rapid response calls, ombudsman, educational tours, all these things happen and have to be in your contract. And CMS is going to require that community integration, all that work. So there's a lot of work here. So how is it working? Snapshot. In just the first year, emergency room usage for home and community-based waiver programs participants reduced by 27%. Again, Representative Boyd, that's where you're seeing savings. That could not, I stress, could not happen in fee-for-service because nobody was managing that. Can it happen in PCMH? Yes. Can it happen in managed care capitated? Yes, you're seeing the proof here. That's not reducing rates. That's better quality service. And then primary care utilization increased 31%. So primary care utilization goes up. Also, there was an increased use in dental, vision, FQHC uses. This is a capitated managed care model working. Decreased days in inpatient hospitals. Now, how can it improve? Where do they point to? The nursing facility. They did not do as well as Tennessee. They're focusing on that, and they're really working hard to get there. And they admit that's the area they have to really look at. Waiting lists. Since the inception, 3,100 people from physical disability and IDD waiting lists have been offered services. And you can see what they've done here to the waiting list. And when I spoke to the state, they actually took $60-some-odd million in savings over that first couple years and took it and matched it with about 140 million federal funds total, actually state fund and federal. So total 140 million, and they used that towards the wait list. The IDD transition, provider and consumer-focused education, friends and family engagement. This was, if you do a Google and check Kansas, searches, you're going to see a lot of concern in the IDD community at the beginning. It was a lot of concern. And they met with the state, and they tried to work these issues out. And they're still trying to work these issues out. This is not, again, these transitions are not easy. How is it working? Denial rate, timeliness of claims, average 6.4 days for payment in home and community base, 5.7 days in the IDD claims for payment. Plan of care reductions were not significant. Again, what does that tell me and our team? Right place, right service, right time. The independent assessments are working. Decreased institutionalization. And this is on the DD side. And I know that Senator Rapert was talking about the DD community. He walked out on the HDC. He had a call. But this is an important slide. It shows they're working in that area on institutionalization as well to decrease the levels. Where are the challenges and opportunities? Right here. Again, when I talk about learning from those models, and Senator Rapert, you're back now. I wanted to show you one of the things here, because I know this is a concern to you on the HDCs. They actually worked in Kansas with the HDCs to make sure the deinstitutionalization works with families involved and others, that because they recognize this is a very difficult issue. And that's one that they're focusing on. It's not going to be 100%, but they're going to continue to improve. And that's why you can learn from some of these models. The challenges, they say, opportunities to build a person-centered nature of care. Through our first 4 months, MCOs have provided almost $1.4 million in lieu of services to more than 600 members. What that is about, there's a couple that have done supported employment. Was not part of the original program, but they're doing some other added-on value items. Anyways, for more resources, this is, again, Kansas's deck. I'm giving them, citing the reference. They did this. I wanted to make sure you had it. Other examples, the Kansas example here is new. We just learned the 2016 budget includes $50 million in state funds, Medicaid match, as a result of implementation of the full integrated Medicaid managed care contracting, and they're talking about putting more towards home and community base for the HCBIC waiting list. That's the home and community-based services waiting list. Ohio example here, 2012-13, budget results were $360 million in state match funds below budget. You can continue to see the savings. Louisiana, we read a few of the Louisiana reports. We contacted them. There was some issue on the difference between PCMH and managed care there, and I wanted to make sure we really targeted those differences, which we'll show you. Again, savings. So the issue comes down to contracting, too, that we talk about a lot here.
John, I just want to make sure I can understand these. You've got 3 examples on here. So Kansas, we're saying in fiscal year 16, which they're probably going to be entering in 2 months, so $50 million, and then if they've got, I know they don't have the same match as we do, but if they did, if they had a 70-30 match, then they would get another $110 million of federal money, is essentially in addition to the 150. Right. So that'd be something like $160 million in savings is what they're claiming. Whether truth or fiction is, for all endless debate, but they're claiming that. Yes. And then on Ohio, they're claiming $360 in state match. So let's say they were a 50-50 match state, that would be $720 million in savings in 12-13 if they were a 50-50 state that they're claiming, and then they're claiming that in 15, the year just ended, that it's $1.8 billion in Ohio. Obviously, Ohio is much bigger than Arkansas, so $1.8 billion a year is not realistic for us, but Ohio is claiming $1.8 billion from 360 to $1.8 billion, and then Louisiana, we're talking about $135 million, and it's unclear to me whether that's the state share or the combined state-federal share, but either way, it works out to a 12% reduction in their numbers. Okay, I just wanted to make sure that I understood those numbers, because again, the only reason we're even having any of these discussions is because we've been challenged as a group to come up with savings to the Medicaid program for Arkansas taxpayers, and that's the only reason we're here. So if we can't see our way to that, then we're never going to take on this kind of a difficult challenge. So it's heartening to me to see some of these numbers from this, so thank you.
So if I go back to the Kansas slide here on nursing facility beneficiary counts, and you look at that, and you can see where they're slow, but they're coming down. And that's going to be significant when you look at your numbers, because that's traditionally where a lot of the savings are starting to be had in these models. So you go down and you start looking at Ohio here. Ohio, one of the main reasons Ohio did very successful is their rebalancing long-term care and the nursing home issue. And again, that was the same as Tennessee, your neighbor. Tennessee achieved remarkable savings in that area and produced a lot growth in the community-based care, as you saw. So again, that's where you're getting a lot of these savings through the managed care program. And I'll stress again, it is not happening in the fee-for-service program. The incentives and sanctions here, these are contracting issues. I thought it would be helpful. We looked at some of the contracts to let you know. That's why I keep going back to how important it is that your contracts have both sanctions and incentives, gain share, risk, and I'm going to keep saying risk, 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 because there needs to be some skin in the game in order for you to really achieve those types of savings you're talking about. And that skin in the game can be like what Richard said, making sure they ensure quality, making sure that they have increased immunizations, making sure they have increased community-based care settings, develop capacity. You could do a lot. And here, financial incentives are used to motivate clinical outcomes. Again, I don't need to keep going over this, but that's what you start seeing in a lot of these contracts. And what has happened over the years is the managed care of the past has evolved. And it's evolved into this value-based situation you see today. Again, whether it's a PCMH or a capitated managed care, it has evolved to where you're getting, the state taxpayers are getting value, and you're paying for value, and you're monitoring it effectively, provided you have the right contracting staff. And that's something we'll talk about later. So when we get to our models in the recommendations, just to go back over, we talked about this already. So in scenario 1 in our recommendations, that is what we called managed fee-for-service, is your PCMH shared savings. It's no different, it's the same model. So I want to make sure everybody knows, that's managed fee-for-service. You're still having a fee-for-service, the state is still at risk, but in the PCMH managed fee-for-service, you're going to shift some risk to those providers. In the scenario 2 or 3, all the risk is shifted to those providers, all of the risk. So if I say, we're going to give you $500 a month for this population, PMPM, if it costs you $700, you're on the hook, and we may rebase the rates the next time around because it'll be actuarially sound. We'll have to figure out the increase and what that'll be down the road, but you're going to be liable for those losses. And that's how this works. I'm being simplistic, but that's how this works. Again, at the end, shared risk. PCMH, shared risk.
So explain, I understand how in managed care you share the risk. The company comes in, they bid on the contract, they understand what they're bidding on, they get a certain amount of money, and then the way you described it earlier, if they save money against that, we can right into the contract that we split it with them. If all the estimates are wildly off, the next year we're going to need to do something. But obviously, if all the estimates are widely off, we're going to eat that in a fee-for-service anyway, so it seems 6 of one, half dozen of the other. But how do you get the risk sharing in a PCMH model? I don't understand that one
So
yet.
again, this is where your creativity has to come into play. This is not, many states do it differently, and it's all about value-based contracting. So I'm going to give you a few examples, and these examples may not be the ones you end up doing, but at some point, the department is going to start creating the models and bring them to you, and then you look at them, and sometimes it's a legislative review, working with departments. So let's use the nursing home issue. So you're going to have a responsible provider, a nursing home, we'll say. A nursing home will have, or if a nursing home wants to be a responsible provider, they have to agree. This is, again, Representative Collins, this would be in my world. You can develop these models every different way on shared saving PCMH. They would be Company X. You're responsible for this number of nursing home, not nursing, but elders in the elder Medicaid program, 100 elders. And we're going to give you a profit sharing. It will give you an amount to take care of those elders. But if they end up staying in the community, you will make more. If they end up going in the nursing home, you're going to end up making less. And at the end of the day, it's going to be such a small amount. Some of these managed fee-for-service amounts are like 25, maybe it's $25 per member per month. Maybe it's $100. You'll figure out what that amount is. But for that amount, you are required to do X, Y, and Z. You have to work on effective transitions from nursing home. You got to do everything you can to see if a senior can live at home. Try to find a family that can take care of that senior. Because if I can do that, at the end of the day, I make more money. I'm managing that population, and that's a provider. If you do that outside of the managed care, the full risk isn't shifting to that one provider. It's a small risk, Representative Collins, but it is a risk.
But what you just described, and again, maybe I'm not understanding it properly, it sounds like DHS is then converted into a managed care company where they have to invent their own contracts, and they have to invent their own protocols, and they have to reinvent the wheel, and we're already concerned that they're stretched and their contract skills, et cetera, are not at a level to write 3 or 4 contracts. But the way you're describing that type of an approach, if I have to write a new contract for every subgroup of providers across the state of Arkansas, that just seems like a daunting task. Am I misunderstanding something with that?
Again, there are different ways, but you're not misunderstanding. And that's why McKinsey, that came in a couple years ago looking at this, said in order to do PCMH, you'd have to have 100 new FTEs. In order to do managed care, it was their recommendation, I believe, 20. So we think it's probably more than 100 if you do it the right way. You have over 400 in one of the slides. You'll have over about 400 contracts. But can you make that, can you do it so that you can shrink the number of contracts? Yeah, you could make it maybe 100 contracts and make more people in that accountable provider pool in the high risk. But they're going to have all health homes, and the provider's going to have to make sure they do everything they can to meet primary care, to meet waiver services, or in community service, or even in the institution, to make sure that their utilization is appropriate. Lower number of SOARs, bed SOARs for seniors, quality standards. But again, managing that 100 or so contracts, yes.
So last question for me on this right now. So there are 40 states you walked us through this morning that have some type of managed care. You just reviewed a handful in some level of specificity that have relatively recent programs. Is it a silly idea to say that we could go to Kansas and Tennessee and 3 or 4 of these others, line their contracts up next to each other, study those contracts, Section 1, have our lawyers look at them, Section 2, talk to the person in Texas or Kansas and find out what's working and what's not, and literally, like building blocks, build an Arkansas contract for a managed care using a handful of the ones that have happened successfully recently? I mean, is that a ludicrous way to to start if we had people that knew how to handle contracts well?
Well, the last point is probably the most important. But yes, you could, in our recommendation, we actually put an appendix for a number of things we wanted DHS, because we didn't know if we were going to stay around. We didn't think after the report, but we wanted them to consider if you move down that road. So there's, yes, to answer your question, absolutely. But I want to say one thing. There are problems you're going to find in every state. And I've said this before. You could call Kansas tomorrow, and you could find providers on the streets and other areas that have complained that this was an issue, that was an issue. It's not going to be perfect. But yes, to answer your question.
Representative Boyd, you recognize for a question.
So, Mr. Stephen, just to make sure I'm clear, so whether we go PCMH or we go managed care route, so this door or this door, because we're in agreement, we got to do something, but I understand you, from a personnel standpoint, we're going to grow government in order to solve our problem. We're going to have to hire more people to do that.
Yeah, I'm not there. That's not what we said. What we're saying is...
You said one was 100 people, one was 20.
Yes, but to focus on those particular issues. What I think you can do if you start really dissecting the department, there are a number of positions you can eliminate. But the point is, you're going to have now 100 or so, and the way that states operate, they always assume that means more FTEs. But you're going to have to bring in additional experience, absolutely. You're going to have, and according to McKinsey's, in which we tend to agree with, I think there was on the low end, you're going to need a whole new division monitoring contracts. Can you find 100 positions in DHS to eliminate, to account for that? Or you can have 20 or so, with some states like Tennessee, probably comparable. You might 20 for managed care, as long as they have good competency in vendor management, you might be able to do it, but we might even recommend a little more. But the issue is, Representative, you're managing 400 contracts versus managing, 3 or 4.
Okay, so I get you.
That's
I
the
mean,
issue.
we're on the same page.
Yeah.
But my point is there's been a question asked to you about the savings with PCMH versus managed care, because it's this door or this door. So we keep hearing you're going to have 100 positions here, maybe we can find them there, and then we've got 20 over here, who knows what those 20 cost versus this 100, and whether or not we're going to be able to
Yes.
to do that, reduce positions elsewhere. So at the end of the day, when we're talking about the size of government, the dollar is probably the better way to measure it. And so we need to see something that says, if we go down this route versus this route, where's it going to be?
I'm so glad you said that. So we'll go to the next slide, because timing's perfect, Representative Boyd. This is, the assumption that we used was Louisiana. So Louisiana struggled with these issues for a long time. Louisiana had a shared savings model, which was it was a traditional fee-for-service. They went to a PCMH. It's PCMH with shared savings. That model saved 6.8%. They also, at the same time, had a capitated full-risk managed care, and the savings were 12.7%. They added the new employees we were talking about. They had it for both ways. They looked at both of those programs, and they've decided since then to move fully capitated managed care because the savings were greater on that side. Now, I'm not saying that that's going to actually happen here, but that's what we use to model our savings estimates. And we feel strongly, looking at all these states, and I said this earlier when you weren't, I don't know if you were here, but we can't find a state, that has a PCMH shared savings model that saves more than a managed care. We can't. But if you can find it, I'd like to see it. And that's where we are. Now, so what we did was we took the state, your neighbor, and closely aligned, and we said, let's look at the savings compared between those two programs. And, I'd be happy to share more information with you, but that's the best we can get for you right now. And please understand, this is what I said, possible savings, estimates. We don't know how it's actually going to roll out, but it has to be done the right way. Either way you go.
Thank you. I think you're starting to address my concern, which is we don't really know, and once we begin dismantling Medicaid a certain way, it's going to be nearly impossible to bring it back. So it's like, at the end of the day, we've been asked by the governor, the way I understand it, to find $200 million in savings so that if we keep our expanded Medicaid, we save $60 million out of general revenue to pay for that population. So as we move forward, and we got door number one, door number two, or some combination thereof, how are we gonna achieve that, and at the same time, not already hurt care that's already great in that population?
So this starts
I mean, we showed you earlier, Connecticut switched back, Oklahoma switched. I mean, that happens a lot. And, I mean, it happens. So the question is, make sure you do it right, no matter where you go, and make sure you take these lessons that have learned from all of these states, Representative Boyd, and use them to your advantage. And I think you can, no matter which model you go down. But I'm gonna say it one more time. We cannot find a PCMH, a state where PCMH has saved more than a capitated managed care. And if you find one, I'd like to see it. And we will definitely make sure we review it as best we can. So when we look at these assumptions in Louisiana, I want to make sure so you understand when we put our savings target, because it has to do with the PCMH model savings, Arkansas works as well. So when we looked at the savings for our model, we knew you already have a segment of your population that's going through payment improvement right now. So we took away the savings that were estimated on that already ongoing and deducted that from the Louisiana savings model for each PCMH and managed care capitated fee-for-service. And that's how we arrived at our different levels of savings. It's a projection off of the baseline, and it's really a top-down savings estimate. So what Arkansas works, and we're going to get into that in a minute, what we were looking at was really to kind of do a top to bottom up. That's a very difficult exercise. You need to really identify a lot of different pieces. But we can definitely do a top down based upon all these experiences. And if the Arkansas Works proposal is closely aligned with what we had for our recommendation, then we feel comfortable with the savings estimates. So that's how we arrived at what you're going to see. So again, we talked about the base.
John, I've got another question. Representative Boyd, did you get a chance to finish yours? Okay, Senator Rayford, you're recognized for a question.
I actually thought about not asking the question after a minute, but I'm going to go ahead and say this because we're getting short on time and we're coming into December and needing to make a decision. A lot of, it seems like that a lot of the discussion, and correct me if I'm wrong, is really focusing on the ABD population right here, right?
Correct.
Age blind as disabled. But yet, just as Representative Boyd had mentioned, that we're looking for a lot of this savings so that we can continue the private option, basically. Some people like to call it one thing or another because it's a little politically charged, but I'm going to say what we passed was the private option, which deals with a new group of, if you forgive me for saying, able-bodied persons that just were uninsured. Is that correct? Mm-hmm. What I'm hoping that as we do all of this, and I'm kind of looking over at Representative Boyd, is that the aged, blind, and disabled are the people that really don't have any other options, whereas the able-bodied working people or working poor, whatever you say here in Arkansas, the only thing impeding them from private coverage is it better pay, obviously. In most cases, a better job and having the money and the resources. So again, I started to click my button and not say this right now, Mr. Chairman, but as we're looking at all this, my fundamental premise has always been that Medicaid was created originally to help the people that truly cannot help themselves. They have no other option. And so I have no problem with managing that very well in terms of what we spend. We should not have excesses in any of those spots. But I don't want to see us cutting into service for the aged and the blind and the disabled that really have no other option whatsoever to try to provide dollars for a class that is in much better situation probably physically than the people that we're cutting from. Does that, maybe I'm stating, I see some nods, so maybe I'm stating that clearly. So, you know, as we start dialing this in, Mr. Chairman, I just want to make sure, you know, what's our focus here with what we're doing with Medicaid in general. And that is, I don't want to see us sacrificing, and I will say this so that it's on the table as it relates to the disabled, which I've made many statements in here before, okay? I don't want to see an alternative given to someone that's able to be in a facility where they get interaction, they get rehabilitation, they get services ongoing throughout the day. I don't want to see that level of care sacrificed and we park them in front of a television with somebody being paid minimum wage, playing Xbox all day long, babysitting them, and they get no interaction whatsoever. Yeah, you can save money doing that, but that's not a life, and that's not doing right by some of these folks that can't advocate for themselves. And so I guess since I did get the mic quickly, I almost shut that off, so I didn't say that, Mr. Chairman. But as we head into this, I guess, putting a little my own opinion out here right now, that I want to make sure that we are not really hurting the population that we should be helping, trying to save money to help an expansion of population that simply has a dollar problem, maybe not a physical problem. And so I guess I did say my piece on that.
Yeah, no, and I think, you know, you speak for all of us in terms of the goal here is not to detract from anyone's care. The whole concept of all of these options, as I understand it, and if I've got this wrong, then, you know, I need an education, is to deliver quality while also bending the cost curve. It's an and story that all of these are designed to do, and I think that notion is embedded in this entire option set, whether it's PCMH or managed care or anything else. Nobody's talking about taking away necessary care from folks. So I think we're all together on that.
Yeah, I think it's a great point. Senator Rapert, your concern is a good one. And, you know, having managed a program like that for 4 years, yeah, I always wanted to make sure that that didn't happen. But again, I go back to just don't lose sight of the fact the amount of authority and control you have over your very question through the contracting and compliance and oversight and that process. And whether it is PCMH or managed care capitated, you can really hold a lot of these folks' feet to the fire to bring the best quality in the setting, and I would say this at the end, in the setting that family is best for them, so they have choice, consumer choice, and have good quality. And that's the ultimate goal here. But when we looked at your program, and you know, I recognize the question, private option versus, there was two issues here. The traditional Medicaid program we were to look at, and we saw a lot of areas that we know can be improved to provide good quality care, make sure long-term it's sustainable for the taxpayers. Because where it's going today is not going to help the individual that you want to help in the long run, because cutting rates is not going to be the answer for that person.
And now, since I'm still live here on this, Mr. Chairman, I'll put out another, you know, I've been inquiring of a lot of people, but I've also had a lot of incoming, you know, to me the past few weeks. And obviously, I don't find any physicians that are excited at all about any managed care, new managed care options. And for that matter, I don't find that from the pharmacy arena either. I think they've all had enough of micromanagement to a certain degree. But at the same time, I also want to just state it as well, because I even have to be careful that when we're speaking about the issues that we're dealing with, which are Medicaid and what the state's providing, oftentimes I think some of us get back into the ACA mentality of choice for the individual consumer and all of your insurance plans, et cetera. It's a different matter than what we're dealing with right here. And so I calm myself down a good bit when I think about the fact that what we're dealing with here and trying to come to some decisions on are the Medicaid population, which government is paying for. And we have to be able to manage that, and manage it very tightly and keep it under control. But at the same time, when we invoke the private option side of things and it fades back into the ACA arena, that's a different ball of wax that begins to evoke some different emotions and many of the members and things of that nature. So I guess what I would tell you is that I'm beginning to feel very comfortable heading into December with a posture that, yes, we have to control costs. And that simply means that there's got to be hard decisions that have to be made. And I want to see the state make a good business decision on this. But at the same time, I hope that as we get to this expected savings, that we're not robbing Peter to pay Paul, so to speak. And because I'm not going to be for any dilution of true quality when it comes to the aged and blind and disabled, just so that I can help this new expanded population, I guess is what I would say. So thank you, Mr. Chairman, and thank you for your remarks. And I do look forward to hopefully a lot of interaction on the committee and some input as we head into December, Mr. Chairman, because I don't feel like we have much consensus yet, is all I would say.
I agree with that. You recognize John to continue.
Yeah. So, but what I'm trying to do to develop that business case that Senator Rappert talks about, to give you the background on all the different models out there, because at the end, the policy decision has to be made. So when we go back over, I want to make sure that's, when we look at the savings estimates here in the two models, I think it's really important, and Senator, this is another issue about quality. You've got a managed fee-for-service here, and we came to the $700 million estimate, again, on savings based on these other state models. Again, but that assumes, and I want to make it clear, it assumes there's shared risk. So if you look at this model and you have just, in the Arkansas Works, I actually did a find on my computer to see if I could see even the word risk. There is not even the word risk in that Arkansas Works model that Representative Gray wanted us to, to cost out. There's not even the word risk. I assume that she wants risk, some shared risk, and I assume you do too, Representative Boyd, if that's the model. So I want to make it clear that when we reach the $700 million savings estimate over that period of time from 17 to 21 in the PCMH model, a lot of that is dealing with your rebalancing of the long-term care nursing home population, the pharmacy savings that Rory's talking about, and the issues in better contract management, and stuff that is going to improve quality in the long run. But here's a big difference is you're not going to have a premium tax too. So some of the savings estimates that you see that we raise on the managed capitated plans, there's going to be a premium tax added. If you look, that premium tax is a pretty significant amount. There's about $347 million over that 5-year period. And those dollars can be used to take folks off the wait list. They could be used for whatever you decide from a policy level. But I just want to make sure you all recognize that, and using the savings estimates in other states, you're going to probably find additional savings based on a capitated model, because the managed care companies have figured out the best way that we've seen how to really ensure quality and also meet savings targets. And so when you go back over the savings models, I wanted you all to understand when you make your decisions, this is how we arrived at our decisions. So when we look at Arkansas Works, if Arkansas Works has the shared savings and shared risk, you can achieve, we believe, savings up to possibly in the vicinity of that $700 million over that 5-year period. So the other issues here, we've talked about the common service level savings. These are savings that are going to happen in both programs, and that's why I call them common level savings. If you do a better job, and as you get close to decisions, Rory mentioned pharmacy issues today. There are things that you could be doing right now to start bringing savings to your program. There are contract issues that you can look at right now to start bringing savings into your program. And hopefully those will be in your report, if you agree to, in December. And then the department will get the initiative and start to move in the direction that they need to move. Program integrity, good news, you've got a RFP that's on the street right now in your Office of Medicaid Integrity. And we talked about that enterprise hub and our recommendation. They've already moved forward on an RFP to bring in that data analytic type focus in looking at provider claims. And that's going to help. There's going to be additional savings in program integrity in the coming years. We talked about the PDL and some administrative savings. So this is the slide. I wish Representative Gray was here, because I know she mentioned something about 30% reduction in nursing home. It's not exactly 30%, and I'll show you, but I want you to focus here on this, because this is where a lot of your savings is going to be. And Senator Raper, no matter what happens here, when you are able to look at, your nursing home population, and you say a certain proportion of those can be in the community living independently, but just don't have the support in the community. And if you're in the emergency room and you don't have that support, chances are that's the place, and the nursing homes here provide great quality. But if you know it's $27,000 on average for the best care here on average versus $70,000 in the nursing home, if you can start really putting focus on that community for the long-term care elder population, that 5-year savings amount, in our estimate, is close to $500 million. And that's significant. And you're not you're not downsizing your nursing homes that significantly. And I'll show you why. This is what we're talking about here. Your estimate today, 11,958 on the census. It's down to, I think, 11,500 or so now. It changes, but it's coming down, which is good. But the home and community-based care census isn't going up as much. So when you look at where are you today, estimated for 2015, and you look on the far right is your 1.1 billion amount, and if you look, 65% of your funds, 757 million in the third column, 757 million is going into nursing homes, facilities, private facilities. 65% of all your long-term services costs. You look at your home and community-based costs, your census is 14,847 at the time we did the modeling. That's 35% of all your long-term care service costs are going into home and community-based care. If you go back down to the next column is, and I know Representative Gray talked about baseline historical. If you did want to look at historical, it may be less than the 14,000. But you still have an aging population, and it's still based on census growth, and we use that 3.5% growth, national growth. If you don't even have that growth, then you'll be somewhere around maybe you'll be around 1.5 something, and you're still going to have significant savings if you can get down to where number 3 is. The third box is this is even a less aggressive approach than the state of Tennessee. And I look at, can you in 2021 get down to a census of 9,695? That's not a large drop. That would tell me that 50% of your dollars are going to nursing home and 50% are going to your community-based care. And the rates in both have increased. And along with that comes the $500-some-odd million in savings. And Representative Gray, I wanted to make sure you saw this. This is what we use. It wasn't 30%, it's 19% is what it is. So at the end of the day, the question comes down to who's going to manage that to get to those targets? And if you can get to those targets, that is significant with, Senator Raper, enhanced quality. And that's what we're talking about. And then this is where the baseline savings come from in that particular area. So we think you can achieve that in the PCMH model if there's risk. We think it's going to be easier to achieve it in the managed care capitated model because of the less amount of contracts and the management issues. But it's not that it can't be achieved. So the next slide is your contract issues, and there are contract savings here, and we've already went in our report a lot of the savings here, and I don't want to go in detail. It's getting late in the day. I just want to make sure you see there are going to be additional contract savings. In each model, you're going to have additional contract savings. So now you're talking about additional contract savings. Rory, on number 63, spoke earlier about the pharmacy savings. And you can move forward on those issues today, with or without PCMH or managed care. And hopefully, some of them will be in your December report. Program integrity, we talked about, restructuring benefits, developmental disability, rebalancing savings. I know this is an issue, Senator Raper, you brought up. Those savings, if there are any, are not included in that $504 million figure. So those would be in addition to, and it's some of the issues that PCMH or managed care would look at as well. So in the end, and this is sort of where we feel, you know, you could look at it, a reasonable estimate is anywhere in that $700 million range. In that PCMH model, Arkansas Works, as well as our model with shared risk, can achieve that $700 million baseline level, provided, again, there's risk. But the managed care capitated will, in our opinion, achieve higher savings. And we've already talked to you what the reason was. So now, moving on to Arkansas Works, I don't know if you want to get into every detail, but what I tried to do here, Representative Gray, and you wanted us to look at this, was actually look at every single...
John, can I just interrupt you real quickly? Representative Boyd, you're recognized for a question.
Which slide do you look at?
Representative Collins, thank you, Mr. Chair. I think I answered my own question.
Okay. All right, John, go ahead. You're now going to talk about the, excuse me, I've got Senator Ingram, you're recognized for a question.
John, we've talked today about some things that could be done right away. You just touched on the contract recommendations. Why would we wait a month? I mean, why wouldn't we do this now? I mean, why wouldn't this be done, put it under review for the savings? I mean, instead of sort of talking about it, start it. I mean, I don't understand why we wouldn't want to, if there are potential savings out there, why we wouldn't want to pursue those now rather than maybe wait just to have it part of a report that's going to be 2 months from now.
Mark White is here. I don't know if Director Seelig is here. That question really needs to be directed to them, but I can tell you that, Senator, there are some areas that they've actually, I found out today with Rory, they've actually started to move forward on some of the pharmacy issues. But I think here's, for the more global thoughts, the contract renegotiations, saying to one of the providers, look, your indirect costs at 32% should be market basis about 10% actually. We need to talk. Let's renegotiate. That's not going on. And why? It's because, in my opinion, everybody's waiting to see what you all do here in terms of recommendations. And that's just what I'm hearing and feeling. I'm just answering the question honestly. I think there needs to be some movement because the governor has made it clear that savings are important. You know that. You've looked at it. But what can you achieve today? And that question that Senator Ingram raises, in our opinion, our full team, is such an important question. You could do more with rebalancing long-term care right now today. And I know that they're thinking along that line, but you'd have to direct that question more to the department.
Mr. Chair, when Mr. Seelig comes up, we'll let him discuss that with us. Thank you.
All right, now, John, so I just want to make sure for the group, what you're getting ready to talk about on, what you've set up with page 65 and what you're getting ready to talk about with 66, just to make sure everybody in the task force kind of understands where we're headed. Some of the task force members had some outstanding ideas that they shared with John that kind of took his base program and made some changes against that. And I asked John to give us some cost and other impacts on those, and he's calling it alternate proposal Arkansas Works. Am I interpreting that correct, John?
Correct.
Okay, and so what we're going to do now is you're going to walk us through the difference between what that program, those program changes would do versus your baseline that you just kind of went through on page 65. Am I understanding that correctly?
Yes.
Okay, so we start off at page 65, and then now you're going to go with the changes that alternate proposal would make versus that.
Correct.
All right, thank you, sir.
And what we've done is lead up to the fact to let you all know how we arrived at the savings numbers, and I think that you have a good understanding now. So looking at Arkansas Works, Arkansas Works was an alternative proposal. It was very similar to the PCMH recommendation in our TSG report. So what we tried to do is look line by line, where are the differences, if any? And there are some, and I wanted to highlight those, but they're not really significant. But I wanted to make clear that we looked at this, we did not see, Representative Gray, you were out when I said this, we didn't see the word risk in that plan. So we assumed that along with shared savings, you would want the shared risk model. That was the assumption we used when we based our own savings estimates. I want everybody to know that, okay? So when we look at the recommendations of the Arkansas Works, again, this is a pretty detailed report, but line by line, you can see on slide 66, the mandatory premiums, the premiums for incomes with more than 50% FPL. They basically agreed with our recommendations, but I think that it was unclear, but I believe they would do the work agreement, and if you met the membership agreement, you may not have a premium applied. But the savings estimates that we did were not based on the private option. They were based on traditional Medicaid. So I'm just trying to give you an idea where you differ from ours. No differences here. Work referrals, strengthening program integrity, integrating Promote Healthy Arkansas. This was a little different. Health education, Healthy Arkansas for all Medicaid enrollees, including some, not just private option, but there was not enough information there for us. But that's, I believe it's probably all enrollees. It might be small, there's going to be some costs. Expand PCMH, proven cost avoidance. That was included in our what's called managed fee-for-service. So include wellness exams, reimbursement to physicians for adult population in traditional. That is not in our proposal. So that recommendation will assume some added costs. Again, we think you could end up saving money in the long run by having lower utilization of ER. But again, there's no real hard evidence we could use to really show you an amount of savings. From the bottom up. Top down, we already discussed that earlier. Stop further expansion of episodes of care. We felt that the episodes for specialty care may continue under our PCMH model. In the managed care capitated model, it would all be up to the plans. But very similar, not a big disagreement here. Increase reimbursement to providers for vaccinations. You heard our recommendation this morning, same. Remove cap on a number of office visits. We think there's going to be some cost there. It's difficult to estimate, but it's the same issue. In the long run, it may end up saving money. Increase laboratory, remove the laboratory cap, same issue. But again, I don't think we're talking about large amount of cost compared to the amount of savings. Include limited reimbursements on visits for diabetes self-management, no costs. Not enough information, but again, same thing. Review the prior approval process for cost effectiveness. This is absolutely assumed in the PCMH targeted model that we had raised as well. Promote telemedicine for specialist services. This is going to be some new costs, but we would have to get more information on what the intent is. Independent assessment, absolutely included in our recommendation, and a lot of the savings are going to be dependent on this assessment working appropriately. PCMH model led by local DD providers in conjunction with physicians, absolutely. Again, that would mean that there's got to be some shared risk too, which is just something that's not in the system today. Reform the ACS waiver, keep the current 1915C waiver. I'm not quite sure exactly what type of reform we're talking here, but if it's similar to what we were saying in terms of our global section 1115, to combine some of the waivers, that's what we were thinking. I think in management savings alone, time, effort, absolutely a good thing, very consistent. revoke the DDTCS state plan amendment. Under our recommendation, all of that would be taken care of in a Global 1115 waiver. Apply the 1915I waiver to bundle and include current services. That's, again, very similar. But remember, the 1915I, you can put a cap. So you can, what we're talking about in the 1115, you can do that under the global sense as well. So it's really, the reason why we like the 1115 in global is because you can effectively manage right service, right place, right time. So, and there's no permanent cap on an I, but you can put an I cap. Develop supportive employment, very consistent. We think that that should be in the contract, and that's something that would be in both contracts. Independent assessment, again, included. Behavioral health home under PCP, that's included. That's our health home recommendation, the department moved forward on as well. Revoke state plan amendment. There wasn't a lot of information there on the behavioral health state plan amendment, what areas, what aspects. But again, we assume that that would all be covered under the 1115 and achieve what you're thinking to achieve. Again, the right service. 1915I waiver, it's the same thing that we talked about. Your state can control the behavioral health costs. And in the behavioral health area too, you can also, through the Global 1115, you don't have to have restriction on some of the provider issues that you had, but it could be watched under that waiver, and it would be managed in the PCMH or managed care service. And Richard wants to talk about the I waiver.
A lot of states have looked at the I waiver, and I want to be real clear. The construction is this an entitlement without a cap, or is it a state plan amendment with a cap? The answer is that the I waiver allows a state to put in home and community-based services and rehab option services, and if CMS approves, additional services into a state plan amendment. It allows the state to say they're going to serve a total of 10,000 people, okay, at this cost, whatever it is. What it also requires the state to do, that when you meet the 10,000 people, you cannot have a waiting list. You are allowed, you need to do an independent assessment when you start this I waiver with your eligibility criteria and your benefits. What CMS allows the state to do when they reach the cap is request that the state change the assessment criteria, which theoretically, if you don't have enough money to pay your prior I waiver construction, you would increase the acuity level on the eligibility. You can do that. But what you cannot do is change the package of services for the people that already are within that 10,000 at that 10,000 cost on that original assessment. This is real tricky. This is not an uncapped state plan amendment. I'm not trying to argue against it. I just want to make sure that you understand that. It has some benefits. 17 states are doing this, unlike CFCO, which is a straight entitlement. You do have a little bit of control, but at the end of the day, this is an entitlement.
And one of the things that, the reason why I think we recommended a more global cap, it's very confusing. What Richard's talking about is another waiver. They've got a number of waivers over there. They've got people managing each one of these waivers. There's different reporting requirements. And what we had said to make the system easier for the state as well as individuals is one waiver that really captures the entire program, right service, right time. And I'll give you an example. A senior on the elder choice waiver needs modification, maybe needs a handrail, maybe needs something done in the house to stay there versus having to go into a nursing home. Well, the particular waiver doesn't have that service, but if you were in the DD waiver, you'd be able to get that. We're talking about eliminating that. What do you need, and can you show that it's cost-effective and meeting quality, and make sure that service gets to that senior so the senior doesn't have to go to the nursing home, and not argue over which waiver. And that's where I think that, where Richard's coming from too. And it's very complex, but again, there are some states that have tried this. Tennessee in the long-term care area, Rhode Island, I was telling you earlier, on the whole program. So it's just a different management. Beneficiaries must have diagnosis of mental illness You know, this is all, we've included that in our PCMH model. Apply a tiered approach. We would accomplish this, again, through the 1115. That's a really good idea. This is really getting into a level of managing where the department would want to come back and show you some of the areas of how they're going to do the assessments and what the type of care is going to be. But this is good. This is something you want to look at. It's sort of like the acuity approach for the nursing home. Allow PCP to bill for behavioral health services in their offices. That's something that was new to us. There's already, obviously, a reason why the folks that put that in there thought about that, and that's a good idea. And we didn't really see it in our meetings, but that would be something you definitely would want to make sure of. Again, it would reduce costs down the road, but there's not enough information to really figure out exactly how much it would reduce. But I think having more behavioral health providers that meet certain criteria, credentials, and are well certified in meeting quality, and if you have a PCMH model or you have a managed care capitated, they are going to make sure that there's really good quality services by good, competent folks. Revoke personal care state plan amendment. Again, a lot of this is basically good ideas, Representative Collins, very consistent with what we would do, what we would want to have in an 1115 approach. And the same thing, apply the waiver, bundling of service to eliminate duplicate services. This is similar to what I was saying. So, define benefits and conduct assessments, benefit limits. I don't know, we weren't sure how that differs from earlier recommendations. Placing caps on beneficiaries, not enough information, but it's something you could also look to in any type of global waiver. Place tiers on services, the same thing. Again, a lot of these issues can be done in a waiver negotiation with CMS. Long-term care, PCMH model with care coordinated between medical director, nursing, facility, community-based care. That's part of the model that we would recommend. Utilizing existing infrastructure in nursing facilities, rural nursing facilities to provide care coordination, home and community, good idea. And that's something we already anticipated. Work to transition more to home care from short-term rehab. We've had nursing home folks come in early on and say to us that they like this idea, they want to be a part of that. I think it's a good thing, but again, if the different management is, you have a nursing home doing it versus capitated 4 or 5 plans and there's 100 so nursing homes, it's just managing. That's really, and then making sure you have the quality and the savings and meet your targets of rebalancing. Eliminate provisional rates, not enough information. That's one, I just really didn't have enough, that we didn't understand exactly what you were trying to accomplish. Cap on liability insurance. We included a recommendation about reviewing that issue as well, but it's one, I think that's where, that was the discussion with some of the medical and especially the nursing home industry, paying a liability insurance on the rate. But the question we had was, were you looking at reducing the state rate, or are you looking at reducing the liability on themselves? There wasn't enough information, but it's a good idea. Increase the thresholds for population-based methodology. Not enough information. Very difficult to understand exactly what that means. I don't know if that's to meet some of the population health issues. I don't know, and we'd have to get more information. But you'll see, by and large, most of this is all very consistent. The PDL list, consistent. Medicaid access to prescription drug monitoring program, it's in our recommendation. Multi-state prescription drug list, in our recommendation. Moving to manual reviews could lead to additional savings, but we need more detail, but again, consistent. This add another 100 drugs to the cap. Rory actually just spoke with the department, and they're actually starting to do that. Again, Senator Ingram, this is almost like the question you asked, and I guess Director Seelig would have to answer, but it's good that we're hearing they are doing some things that really are moving in the right direction. And so we found out about this in the pharmacy area. And that's about it. So they're adding another cap. If you want to know what that is, you can ask Rory a question. prescription drug limits on maintenance medications, some costs, potentially savings in the long run. Reimbursement to pharmacy on immunization, we had talked about that already, and some costs, but we all feel in our group that that's something that you ought to be really considering. This was one we didn't understand because it had two different models. So if you look at managed care for dental, and this is something that has been somewhat confusing because we've heard from different task force members that they're different issues. I want to make sure we clearly identify this for you. The dental home case management TPA, fee for service, want to make sure, I think this is what is intended, but there are two different models in dental. One is the capitated full risk dental, where a plan ends up taking the population, or there are actually two plans in Texas. I think there are two in Louisiana that actually do the managed capitated for dental. And basically doing the same thing I just outlined for you earlier. PMPM, one payment. If it costs you more, you meet these measurements, they're on the hook. If it costs less, there's savings, and they can possibly even share with the state. They increase access to dental for kids. You put it all in the contract. That's one model. That's the capitated managed care model for dental. The other model is TPA, third-party administrator. So those are two separate models, and I know the intent wasn't to have a system with two different models, and I don't think it is. So the TPA model, so that you all know, is the model where it's like a third-party administrator who's it's almost like PCMH, where you're paying a small amount, and they've got to pay claims, they've got to meet access requirements. And if you don't meet certain requirements, you're on the hook for something, or you have to pay back a small amount. If you do meet them, we're going to give you a bonus. That's a TPL, PCMH, shared savings, shared risk model. So we weren't clear. Our recommendation was kind of give you both options. So if you decide in your final analysis to go dental capitated managed care route, it's no different than the discussion here. And you could even say the dental, if you go managed care capitated, the dental plans in some states are covered under the capitated managed care model. And in some states, they have separate dental capitated managed care. So again, we agree with this recommendation. It's just, we just weren't sure which one it was. Implement DRG, you know, I guess the savings here would depend on the policy decisions. That you can set the base rate and you can calculate it to make sure you meet whatever, you know, areas you want, but you also can provide good quality care, and the providers would be, again, thinking about value, making sure the diagnosis is not a long-term stay, really effectively managing. But again, the hospital administration, Children's Hospital, and UAMS are all working with Representative Farrar and also Senator Ingram and the committee. And Stephen's helping them along this way. I will caution you, though, that it's a very complex issue. So it's not something that is probably going to be, you know, determined right away before December. But it's something it's good that you're at least looking into it. Levelized reimbursement rates among state-supported institutions and private institutions. So we need more information there, and I think it may be that there's much higher payment in the state facility, we keep hearing, and we were thinking, you know, if there was a way, you could even have some type of management change where it's, you have an RFP and you have a different management without compromising quality, you could save some dollars there, but I didn't know exactly what you were referring to. So we probably need more information. So that's one, and then basically the next slide is again, very similar to what our transitional HIP program, provide beneficiary health scorecard, promote wellness, create legislative oversight. That's a very important recommendation. So you can see, I think we're just about done. And you can see there's a lot, this took a lot of time, Representative Collins, because there's a lot of little recommendations here that we want to make sure we didn't miss. But you can see here, by and large, they're very similar to our recommendations. So in the end, and this is the 85 slide, is what we feel competent to tell you here. To to do a bottom-up savings analysis here, we'd have to sit down and get a lot more information from what everyone intended on all these different items. But if it meets where we recommended and has the value-based purchasing and the type of risk, that's the key issue. We feel that the core recommendations that will drive the macro cost trend are reflected in the estimates for the TSG model, PCMH, but the savings are going to be that last bullet. TSG managed fee-for-service savings would apply to Arkansas Works, provided there are shared savings and shared risk across the board. That's really the bottom line here. Can you meet the $700 million possible range of savings we're talking about, looking at that Louisiana-based model? We think you can if you do it right. And that's just something that we'll have to wait in the future to see, but we think you can. So we talked about risk here again. Note, some of the Arkansas Work items are potential new cost drivers, and I want to make sure you're clear. There are going to be some additional costs. But I will say, based on what we have seen on the cost, the areas that are going to be cost, long-term, the potential savings too are offset. Again, I feel comfortable telling you the $700 million figure range is probably a good range to be in, even with some of those additional costs. And then the last model, this is to go back over where we were. And what we really like, I think Richard, the one word Richard mentioned today was opportunity. At the end of the day, we know there's some difficult decisions, but I know what you have before you is opportunity. Because if you do it the right way, you are going to get savings. You are going to get savings. You're going to obtain savings, and you're going to be able to then decide from a policy matter what to do with some of those savings. But here are the four models that we used, and this is where our basic scenario 1, 2, 3 all managed here, with the top line being if you do nothing. And again, these are estimates. It's important for you to recognize 2017 to 2021. We're not talking about January. We're talking about a significant amount of time to ramp up. We're talking about lower savings probably in the beginning. But I'll say this to you, and I've said this to you before, and you're our clients. The longer you wait, the longer it's going to take to achieve the savings you need to meet, I'm not talking private option, to really keep the traditional Medicaid program from being sustainable long-term and identify areas you need to fix. So try to move forward as aggressively as you can, but in the right way. And there are many people who are waiting for that decision. So the contracting issues, this is the research we looked at, very high-level research McKinsey had done. 20 to 30 FTEs in the PCMH. This is where we got that from, Representative Boyd. And it's not that much different than what we think you need to really beef up the two contracting areas. And there's a lot of discussion that will happen if you move down with either door on what that's going to look like. And we'll help you map through that process. But I think, looking at the department from where we looked at, I talked to Director Seeley, I think it's like 3,500 employees. You have a smaller number in the Medicaid division, but you have a lot in long-term care and a lot in behavioral health and other areas. I think that you could get to where you need to go by looking at vacancies in other areas and not have to think like, we just got to increase more and more employees, but you are going to have to do some increase. And I think that's where Director Seeley will really help you through that. He knows that department in terms of the number of people. But if you go down that road, he or the department is going to need resources. And those resources today can also come out of the large contractor budget you have. And you can reposition some of those contractor dollars to help them in the FTE side as well. So a lot of decisions. And then I guess I'm going to go to slide 90. Representative Collins, you keep mentioning this about the number of contracts. I mean, this is as best we can figure out here. You got 130 nursing homes, 100 likely DD providers potentially bearing risk, some risk. potentially over 400 risk-based contracts to manage, but you could end up managing 100 of them and pool some of the providers, and you could do it in different ways, and there's ways, you have to look at how other states have done it, and we can help you there, or help the department. But at the end of the day, it is significant to manage these value-based contracts. It is not an easy task.
So just again, to make, for the slow learner group, so the reason there's 80 to 120 FTEs in the health homes is because of is simply the quantity of contracts. Is that the relationship?
Yes.
Okay, okay, thank you.
Yeah, and I would say the complexity too, but then again, capitated managed care, if you do it the right way, is gonna be complex anyways. So yeah, I guess both are gonna require, but the much more intensive focus on, quality outcomes, performance-based management, identifying data. Representative Collins, doing predictive analytics, doing the data, identifying the targeted data and analyzing the data to make sure you meet the outcomes. You have to have IT staff. There's a number of areas that are gonna have to really be beefed up. So the controlling issue, slide 91, is the controlling issue here. And Representative Boyd, I don't know why you're leaving at the right time. This is the big issue here, right here. Who should manage the contracts? And that's really what it comes down to. Whatever way you decide, you want to ensure these are the top key areas you want to look at: quality, performance, access, savings, shared risk, gain share, transparency, improved health outcomes, accountability. And that's what you would tell the department when you start to focus in these areas. Those are your benchmarks, I would recommend. And you're going to measure them. That's where that oversight would come in if you go down that road. And you measure maybe on a quarterly basis, but you're really involved now measuring or looking at metrics and getting the right metrics as you go through this transformation. Because what this is, Representative Collins, is a real, true transformation. That's about it.
John, just, we're currently doing PCMH in 1/4 of the Medicaid budget. Are we doing these contracts and assigning the risk in our existing PCMH here in Arkansas?
Not to this level. I mean, I'll let Director Seelig talk about it, but it's not a performance-based outcome approach. No, not on outcomes. You're more on the compliance side. So if they don't meet a certain target, that they may get penalized. But then there's not a lot of focus on real good quality outcomes, because that's not the way the department is managed. And the department's paying claims. The department's paying claims, but you have to meet the benchmarks of the contract, basic, what I would call minimum standards. But I would have you ask Director Seelig that question. But clearly, not the type of things like to the providers, if you, in the DD space, we'll say, if you are able to provide quality adult day programs, and what Senator Rayford said, and you're able to show that this individual found a job, and that and you did a lot of and you're not just watching TV, and you put the metrics, we're going to give you a bonus. That doesn't happen. You get paid a rate in the day programs. I think you get paid a certain daily rate. You could be there 1 hour or a couple hours. Director Seelig could tell you. Or you could be there 5, 6 hours. And the question is, how do you manage that? And that's not the way Arkansas DHS manages its programs today. It's not anyone's fault. That's the cards they're dealt with their contracting. And what we're talking about is a whole different transformation here of how you handle contracts. It is what the nursing home industry said when they came in to see you and testified, and they talked to you about all these different contract methods. That's a whole different world here. So that's how we would answer that question. Richard, you may have some other thoughts.
No, I think the complexity of contracts is the root issue.
And I think that's, the continued tasks here, we've got a lot. I want the task force to know that there is going to be a report that comes out on the Gartner report of the EEF, and eligibility system. We've talked to the governor's office, we're gonna be working closely to get you whatever information we can. Martha's gonna be meeting, she's coming in to meet with some of the folks. We've got a few other areas. I had a great meeting that Betty Gooman organized for me to prepare you all for the workforce issues that are gonna happen if you go down the road of work referrals. And both Workforce Director Bassett and Director Seelig's teams were there. They're working very well together, and we're monitoring that for you, because there's going to be a need to make sure not just referral, but if there's going to be a not requirement, but a referral, once you're referred, you don't want to just leave them referred. There are going to be folks that you want to help find jobs and take advantage of some of those programs, and then the question is connecting them without them coming to you and saying, we need another 100 FTEs. So there's a lot going on right now to prepare for some of those issues, as well as the eligibility hub. The OMIG's office is working on some stuff that's going to really be helpful. So there is momentum, and Senator Ingram, I want to make sure I didn't want to leave you with the impression nothing's happening. There is momentum, but there could be a lot more.
Senator Ingram, you're recognized for a question.
John, where does the information silos that NSPARC has done so well in Mississippi, where does that fit into, where do you see this fitting in?
That's a really good question. NSPARC, I think that there's a system now at Department of Workforce called it's going to be RWINS, I believe. The director there wants us to go look at it. But I think what NSPARC is, for the folks that don't know, it's Mississippi State University has put together a data integration system. So all the data from food stamps, SNAP, Medicaid in Mississippi is come to a data warehouse housed by Mississippi State University, NSPARC. And they're able to do data research for the departments, and they have these high-end, either graduate students or others doing a lot of value-added work where Director Seelig, for example, didn't need to hire a worker to do a certain thing. But when it comes to workforce, they manage, Senator, the workforce eligibility program in Mississippi, basically the software. They design the WORKS program. And I've asked them to look at our WORKS, or WINS, for you all, and we're going to be setting up that meeting. So at some point, that's going to be a discussion that you all have, and then we'll know what the gaps are and how that can be filled.
It's my understanding that that was the software, the programming was developed using federal grant, and that information, if we decided to go that route, is free of charge to us, the programming and everything. Is that correct? Is that your understanding?
I'm not sure. I'll check into that and get back to you. I have to ask. But I know that they were very, let's say, agreeable to helping the state of Arkansas in any way. And Arkansas State University president and a couple of his members went down to meet with them, and I was at the meeting for you all on your behalf. And I can tell you it was a great meeting to be at, and seeing two states wanting to really work together. And Mississippi, by the way, has the program is nationally recognized because the state of Maine uses their software program for their WORKS program as well. So having both your state and their state working together, your border states, going to be a good thing. And then bringing your university and college system in to help folks that are needing maybe life skills training or something else in the future is a good thing to have. So we'll see.
All right, John, thank you very much. And we covered item E earlier in the meeting, so we're to the last item on the agenda, item F. John Seelig, and would you please come up and talk about timing and process for CMS waiver negotiation? Thank you very much, John and your team. Appreciate all the work that you guys have put into this. Thank you. If you both would just introduce yourself and who you're with for the record. Thank you.
Mr. Chair, I'm John Seelig, Director of DHS.
Sam Bierman, Assistant Director of Arkansas Medicaid.
Wonderful, you're recognized.
Would you like me to answer a couple of the questions that came up first? I know Senator Ingram had a question about contracts.
Sounds good, go ahead.
Senator Ingram, on slide 62, if you've still got it, I think you'll see in the first line of that slide, about 2/3 of those contract savings are actually in the works already. So for example, some of those contracts have to do with our MMIS system. As that goes in place, some of those contracts will go away. So we're in agreement on what can happen with the contracts, and a lot of that's already underway. And the only other, I think, is there a question on
Yeah,
that?
yes, John. Senator Ingham, you're recognized for a question.
Do you really sing Zippity Doo-Dah?
No, sir. And the other thing I just mentioned, and we've not had a chance to talk about this because I haven't seen this Arkansas Works proposal until now. I am very concerned about trying to put our providers at risk. They're simply too small. I mean, our conversation with the providers, if you have a developmental disability provider who has 20 or 30 waiver clients, and you put them at risk for the cost of those clients, and 2 or 3 of those clients got to be real expensive in a year, it could sink a provider. Same with a behavioral health provider, who they could have just a few clients end up in the state hospital or end up in a private psychiatric facility. So I don't know how you would, with as small as Arkansas's providers are, with few exceptions, how you could put them at financial risk for just a few of these high-cost clients. We just have to talk about it. So I know Mr. Stevens talked about it, you'd have to have risk involved, but we talked about that 2 or 3 years ago, and our providers really indicated, and we understood that it'd just be very difficult to put them at risk. That's why, even with our primary care physicians, we have 5,000 clients in a group before we even do the shared savings with them, because just from the actuarial analysis, you've got to have a pretty big number to know that you're either paying the right amount or collecting the right amount back. So it's something we need to work on. And the other thing I just note, again, I think there are a lot of interesting ideas in the Arkansas Works project. Just from looking at this, I haven't seen much. There are some that concern me. For example, if you levelized what you pay and took the human development centers down to what we pay some of the smaller providers. Senator Raper, you know, the clients on the Willow program, the Willow unit at Conway, they're much more expensive to serve. Conversely, if we took the regular nursing homes out around the state and paid what we pay at the Arkansas Health Center, where we have extreme behavioral problems and people with gunshot wound, head injuries, and on ventilators, it would cost the state a ton of money to bring the other nursing homes up to what we pay at the Arkansas Health Center. So you really have to work through the details of a lot of these ideas, I think, to make sure that they make sense. But again, a lot of the ideas are ones that we've worked on before, and I think there's certainly something that could be worked with there. So with that said, Mr. Chairman, if you'd like, I can get into the timing. The main thing I just want to mention is, let me start with, obviously, we would, whatever replaces the private option, and it's obviously the governor's intent to do that, assuming the task force and legislature are supportive, you wouldn't have any final decisions on that until you had a session and dealt with the legislation and saw whether it passed or failed. But there is a lot of work that has to be done before you get to that point, starting with getting a concept paper of some sort to CMS and really, and the governor's talked about wanting to do this, really start negotiating with CMS on what's he had in his idea, the in-the-box and out-of-the-box ideas of the Stevens Group. The more you do or propose, the more creative you are, the more time you're going to need to do those negotiations. So the sooner this task force can give a sense to the governor of its support of different concepts or support one way or the other, that will really help him and the team that's working with him in starting those negotiations. In addition, you've got to work on, once you decide what those components are, let's say there's 8 or 10 things, significant changes, and I think everybody's talking about significant changes to the current program, you've got to work out a lot of the design details, even on something like employer-sponsored insurance. There's many different ways to go with that. You also have to do actuarial analysis on each of those. You've got to draft contracts, rules and regs, et cetera, and then the insurance department has a lot of work to do so that they can give guidance to the carriers on what they're going to be bidding on, in effect, and what their plans are going to look like. So just a whole lot of work that has to happen. The sooner you all can let the administration know which direction you're comfortable going with and the governor going forward with, it'll just be very helpful. The thing, to just let you know, the thing that has to happen really within the next week is for the administration to send to CMS notice that, really kind of placeholder in effect, notice that we intend to amend the existing waiver that we have. Otherwise, what you're going to do is that waiver would go away, and then you'd be trying to put one in place while you're taking one out. The existing waiver, actually, we have built up some savings and expect to build up even more savings in terms of budget neutrality, and doing significant amendments to the existing waiver we have will be much more beneficial to the state than simply getting rid of it and starting all over again. So that's something in this next week. We'll need to send something to the federal government saying we do intend at the end of 2016, and let me just say, when I say we intend to do it, it's something that's always can be retracted. So if the legislature and the governor decided not to go forward with Arkansas Works or a replacement, and this gets confusing because the governor's plan was Arkansas Works, what I think you all put together is also called Arkansas Works. They're not actually the same thing, it looks like. So the governor's intent of doing what he talked about with some in-the-box and out-of-the-box stuff, you could always take it back, but you have to say now, we intend, as we speak, to amend that waiver. We'll get something submitted, and then we actually have to have a couple public hearings to get people's input and do that in the next couple of weeks. So don't want anybody to be surprised when we do that.
I've got a question. Representative Gray, you're recognized for a question.
Thank you, Mr. Chair. I just wanted to clarify, Director Seelig, that the governor's Arkansas Works, what was in this proposal with the Stephen Group didn't have it wasn't in its entirety in the outline like it was presented. What we actually did is took the governor's 5 remaining viable recommendations and filled them in with substance. And like InSpark was, I think, unintentionally left out of here, but each one of the governor's 5 proposals, we just filled in with substance, and then he actually asked to add a 6th proposal, which was his include Healthy Active Arkansas. So that's why we kind of named it that, was we took all of his recommendations and actually helped him substantiate them. So just wanted to clarify that for you.
That makes sense, and I can see that his are in there. There's just a whole lot more in there that at least I haven't had a chance to work through with him and his staff, so.
I've got another question. Senator Raper, you're recognized for a question.
Chairman, this is a good time for me to ask the question, and I don't know if Representative Gray wants to expound on it or you want to expound on it, but when you say you've stated you've taken the governor's proposal and then we have filled in, would you explain to me exactly who has filled this in and who came up with these ideas and where did you get the data, and because maybe I missed that in some of the communications we've had.
Yeah, so, and I'm going to recognize Representative Gray here in a moment, but some of the members of the task force took the PCMH proposal that John Stephen did and put some tweaks on it and wanted to get feedback on them, and that's what he was doing today. So Representative Gray, you can give a lot more details since you know a lot more about it.
Because I didn't know if this is some subset. I didn't know we created a subcommittee within the task force to do this. I'm at a loss of.
No, well, and what we did, we're just.
Representative Gray, let me answer that one first. What I've said forever here is anyone that has anything they would like to feed to the consultant and get feedback on, everybody's welcome to do it. I've said it from the chair multiple times, and Representative Gray and some other folks.
I just need to get a feel for where this data is coming from, so if this is something.
And I'm with you now, Representative Gray, you're recognized to give more specifics on this particular question set.
Okay, thank you. No, it's just several of the legislators that are on the task force and another one who is not on the task force just kind of came together and started talking about some of the recommendations that the Stephen Group had put together, his 3 main recommendations, and we just kind of talked about each one. This is the actual first time we've been allowed to look at each other and have a conversation in the 10 months we've been doing this or however long it's been. There were 5 of us who just kind of brainstormed and kind of put some of these recommendations together and then sought some input from other outside areas. And I do want to say to Director Seelig's comment about like the human development centers with the levelizing of state reimbursements, there was no intent to levelize human development centers in that. It had more to do with UAMS and clinics and how some of their clinics are paid actually double what private clinics are paid, but we can get into that more, which brings me to, I would love the opportunity to be able to present our plan and to the task force, either for, recommendations to change it. This is not all inclusive. Some ideas may be bad, some may be good. We would love the opportunity to actually have some input to try and expand that PCMH model that the Stephen Group had recommended as option number 1. Does that
Well,
answer your question?
It's a start. I'm sure I'll have some more, but I appreciate at least a little insight into where all this has come from. Did the governor's office work with you on some of these ideas that you ended up bringing, or were these
No.
ideas independent?
These ideas were independent. We did present, the 5 of us that wrote this did present to the governor for about an hour one day. He essentially, not one way, didn't say yes, he liked it, or no, he didn't. He just wanted to see if the savings were there before he even looked at it. He did ask that number 6 be added, and that's why the Stephen Group was given the report, was so they could quantify it, just to make sure the savings were there before it was ever actually brought to the attention of the task force. And with that, I must say that I did not realize, I did receive an email yesterday that I now know, I didn't know I had it yesterday, that this report was actually going to be presented in detail today. I did not expect that. I had expected at some point, if the savings were there, that we would be allowed to present it.
Okay, thank you very much,
Yes.
Representative Gray. Mr. Chair, I guess to get back to Dr. Seelig, I always call you doctor, though you tell me you're not, John, is that I do think that your comments about the necessity for us to get moving is very critical as we head into this. There's a lot of things I think we could go ahead and start with. I think that's echoing Senator Ingram. But we have to get started having the conversation and getting some decisions made post-haste. So thank you, Mr. Chairman.
All right, John, you can continue. So let me ask this question. What do you need from us today? We're not meeting again until December 16th. So you tell me what you need from us today, and I'll make the motion, and then we'll see what happens.
I don't think I can say there's anything we have to have today. I mean, if you all made decisions today, that gives the governor 3 more weeks and us to work on it, but I can't tell you today that we've
So
got to have a
I
decision,
can-
so I don't want to.
Yeah, so we're not going to take a vote on PCMH versus managed care. That's not going to happen today. It's going to happen on December 16th or 17th. So that gives us the 24th through the 16th or 17th to work out where we're going to land on that. And then my expectation is, when we get alignment around that, then the whole thing will be voted on in one fell swoop. That's my understanding of how we, from my one-on-one conversations, are going to be willing to do this. But if there's something that the governor needs and absolutely has to have this moment, then let me know what that is, and I'll make a motion, and we'll see if we can get it through.
No, I don't think he does. I would say the more pressing issue in timing is the replacement to the private option, because there's such a long lead time, and that's not something that we can kind of take our time and do.
Yeah.
So that.
Well, what I would recommend, and I'm totally agree, and I'm totally supportive of that, and what I would do are all the pieces that you need to do, and, in order to get the ball rolling, and then anything that we have to have, we've got today, and then we'll be back again on December 16th. So those are the 2 nearest days we've got to do anything we have to do, and then SB 96 means that we've got to have our final report done on the 31st, obviously, of December, and we will achieve that as well. So, but I recognize that sooner and more, faster, better is absolutely is. I'm totally with you.
Good. And that was really all I had to present. I just wanted to make it clear that there's urgency, and that we will be in the next week getting a letter to CMS saying it's called an extension of the waiver, but really we're telling them we're going to want to amend it. And then we'll have a couple of public hearings just to get feedback from people. So I can't imagine there'll be a whole lot to those at this point, because we're still waiting on the task force, but we do need to start that process.
All right, so did you just say that was the extent of what you wanted in this line F? Did we cover everything you want to present? Okay, all right. Are there any other questions from the task force for Director Seelig? Seeing none, is there any other business? Seeing none, excuse me, Representative Gray, you're recognized for a question.
Thank you, Mr. Chair. I just wondered if it would be a possibility for some of the task force members to present an alternate proposal to the task force, either in an additional meeting or during the next scheduled meeting.
Let's talk about it, and we'll figure out if, how, and where we do that. Well, one of the things that I took away and that I'd like to have the Stevens Group involved in is a lot of the ideas that are involved in the additional presentation are improvement-oriented versus what they've got, and the question of savings, what I took away was that it was relatively similar enough so that if we make a vote for PCMH, the implementation of PCMH would get very much into roll up the sleeves with those kinds of elements that are in this report and this update that we're given today. So the central question to me still remains, do we have a hybrid option or do we have a PCMH option? And if the reality is somebody is saying, I won't vote for Stephen's PCMH option, but I would prefer the Arkansas Works option, then it'd be important to make sure we do that. So if we've got some people that are in that camp, then trying to work it in advance makes some sense. But it seems to me if we go PCMH, there's no reason not to consider all of the ideas that were in your version.
Okay, well,
If we go managed care, then we'll try and bring as many of those as we can into the overall health care plan. So in terms of the implementation phase, I'm 1,000% supportive of it. But what I don't want to do is create a delay in the decision.
which is why I had asked for an additional meeting, if possible, in between.
All
And
right,
I-
well, we'll
and-
talk about it.
Okay.
Any other questions? If we're adjourned.
We'll see. Yeah.
And I'm in a city with the worst healthcare in the state with the worst.
Yeah, and I would be,
So
I would be.
I was gonna say, well, I don't want this company, I want that
Yeah, exactly, and that's what I would be.
for my area, right?
And I told them pretty much, you know, managed care does, only way I would even do it all this, we have to know what kind of rates. I wouldn't look at it. In control of how the rates are set, we spend it, change them, especially whatever we've got. We've got two options. All right, second thing is the benefits, the doctor-patient relationship. You know, I don't want you going in and managing it so much so that you're wanting to part today. You know, those things have somehow been spelled out. Now, if Congress changed the rules, then employers get paid. Unlike you,
Congress has changed all this stuff all the way along, as part of the problem.
Not this one. I mean, they never will. But unlike you, it just makes it easier for me. I've got no problem. You have a lot more compassion. They turn me off.
You talking about the private office? Don't put too much of that, because actually, my concern has always been about people who truly want to sit in the public. Who's getting shaft in many cases, trying to help this group who's they're not even sick. We're paying them premium.
And I understand, but to me, they're two separate, totally separate animals. You're looking at people that are in the Medicaid program today, but we're not getting the sham because of those folks at all. But we've got to end this cost curve.
Then, you know, what they're gonna do is they're gonna look at somebody who's showing,
And we've got to do it.
15.
And the other thing I have told
And
you,
they're gonna be the one, it's gonna be their responsibility to why Medicaid is not. At, 15 times a year, is it because, you know, they're supposed to be a doctor for one better, they can't find transportation, so they're just calling you, and we all have whatever they can.
On top of the
You
tax.
know, if that's the case, then they're the ones that are responsible for, you know, making running their transportation, so they can go and call them a taxi for $15 versus, you know, $100 ambulance ride. That's where I see you saying very close. Second thing is too, if somebody has a chronic condition like diabetes, I'm concerned about, again, they can help manage that diabetes, you know, if that person, again, is seeing the doctor 3 times a month because they're eating sugar cookies and they shouldn't be eating sugar cookies. You're gonna be right in the middle of it. They're gonna be, of course, they're not gonna be, you know, buying food for that person, but they're gonna be trying to figure out why this person eating sugar cookies, you know, is there an alternative that they can give them?
Keep chin up.
You know, some kind of medicine that will stop the cravings or whatever, so that they won't because of the sugar.
all right, Phil.
That's where they're gonna end up.
No, good job.
That's where they believe.
Hey, Justin. Hey,
As
Justin.
long as they do that,
One of the things I love about people like you is just keeping on the football field.
whereas we can't do that.
Yes, ma'am.
You're not just, I did real mind there, are they, I just wanted to make sure I was understanding. If the meeting,
That's what they're saying. That's, yeah, and again, in states where it's working,
I heard anybody arguing
being
for total
successful.
That's a lot of benefits.
Well, you know, they say Florida has had problems, but there's also been successes in Florida. Texas, I think Tennessee, I'm not very familiar, but Texas, I think it's done a really good job at their managed care. But that's, again, where they said the contracts have to be written correctly.
Yeah, I see the conversation.
You know, we need to learn how to say things. So that's where I got them,
One of
they
them was a
help
hybrid
out,
managed
say,
care
okay,
PCMH
six
model.
states, maybe states.
One of them was a full PCMH model.
When I talk to managed care companies,
The only
I brought that out to them.
debate I see happening right now is the governor's going to support the hybrid model.
And what you do is they say, okay, here are the rates, and then they bid out on the contract. So
And then
like
other
I said,
people are
you know, the
focused
rates
on the
that,
PCMH model.
you know, I think my
Nobody's
government
pushing
issues
for
make it
I think that option is
say,
effectively
we
on
want to
the
pay the
table,
price
just
just
because
because
it's
it's $5 for it.
Now, the thing that I
Well,
think
then
today
that company will
really
say,
opened
okay,
my
it's
eyes
75 cents.
is that regardless of the option,
It's gonna be $1.2 million where we said, okay, what about the
critical
cents? You know, that
nature
may say it's
of
$1 billion.
establishing this
Now us,
in the provider community, where somewhere beside
delineated in the PCMH benefits for those folks that actually think about doing that. It's a new learning for me.
Save some of the drone benefits.
I just had one more.
Oh, yeah.
So when Director Slade was talking about how there's a
So
year
they
time
say-
to handle some of these changes, would it be possible for them to pull into language, or is that something that y'all have talked about?
I think one of the things that's very, very difficult about trying to manage 400 contracts, to try and build a skill set in an organization, which is essentially a contract management skill set, essentially a managed care type of a skill set, is very, very hard to do, and there's lots and lots of issues with it.
Well, and that's where.
One of them, Director Seelig pointed out, which is anytime we have small populations of anything, it's very difficult to manage that and have aggregate communities. It's one of the reasons that businesses scale up, and it's one of the reasons that the broader we make managed care and all the managed care companies that came here,
Because it may not be the best, and what I'm saying is that.
the easier it is for them to do the dual mandate, which is the quality side and also the cost side. So,
we know.
to me, that additional learning really even made me more in favor of the managed care hybrid model. And they're not going to allow us to because I didn't realize how much complexity would be involved in this. And we could even generate the savings that are less than half what the hybrid model is.
You know, maybe there is.
So you gave us the lead when you,
Outbreak,
first minute, this
you know, that we would accept, that is, you know.
it's down to scenario one versus scenario two. Why do you think that?
Because I think all the discussions that we're having, nobody is arguing for full managed care. We've got, the governor's come out in his letter and in support of the hybrid model. I'm personally in support of the hybrid model. I think a lot of other people that I've talked to support of managed care for expensive populations, PCMH where we have the non-expensive populations. But there's clearly members of the task force that are focused on an all PCMH model. So those are really the two options where I see people making the case why they would vote for one of those versus the other. And I don't hear anybody telling me they want to vote for an all managed care.
What's your sense of where the division is, like percentages?
Well, it's a little bit too early to say where it is because there's a lot of people that are still processing and see benefits to both. And I'm also always leery to put anybody else's vote out there. I really only have any confidence in where I'm standing. So in that sense, I'm for the hybrid model. Again, I was that way coming into today with a lot of the complexity associated with PCMH. In order to build in the kind of risk sharing that we're going to need to get even the smaller savings that the consultant is promising, it just makes me less confident we can do that one successfully. And it makes me more confident that the hybrid managed care is the way to go.
Figured out, are you gonna have a majority vote? This is what you're gonna recommend to the governor, or is the rest of the legislature, or how's that
They
gonna
ought to
go?
go
Want consensus?
by themselves.
Obviously, my goal would be to have consensus around the Stevens Group report set of recommendations. So that you've got the major one we're talking about now, which is the hybrid PCMH option, as well as the Arkansas Works program that Stevens calls it THIP, Governor calls it Arkansas Works, as well as a bag of additional recommendations like the eligibility system and other things that are in this report that he presented October 2nd.
So you're gonna give several recommendations, and let the
I think other states have kind of paved the way.
So what I'd like to do is vote for one set of recommendations anyway, essentially. Now, the challenge is obviously, we've got to make sure we're aligned, is that the PCMH or the hybrid, so we need to specify which one it is. And the more people that can agree, I think the better off we are. Now, can we get 12 people to agree to go with the hybrid or to go with the PCMH out of 16? I mean, that would be a high watermark. Do I see 12?
But what do you do with
all
those folks
agreeing
that are
on
not in the
everything?
pilot?
This huge, too early to say. A number like 12 would be outstanding to me.
Like you said, if we do
Once a
nothing.
few meetings,
I'm not sure I understand what you mean.
and then once a month, I mean, it seems like huge issue, the most difficult issue we have is American politics. And this meeting, I think, into December 16th, might be again.
Well, we've been meeting twice a month since October. And I think with the holidays, and is it possible that we could have another meeting if there was something that necessitated another meeting? It's not like we can't do it, although it's extraordinarily difficult at this late day, given the way the holiday schedule and the room schedule is set up, to try and get something in before the 16th. But if there was a necessity for a meeting,
be open to them. I'm just not sure what that would be.
You're gonna vote December 16th or 17th on a recommendation.
Yeah, we have to, because if we don't, there's no way, Christmas is like the next week. So if we don't do it on the 16th or 17th, there's no way to have the information we need in order to complete the report. So, if you remember when I said we switched from kind of the information gathering and assessment phase into the decision-making phase, that process has really been underway since Stephen presented the report, as people have digested this and thought about what they want to do and had conversations with Stevens and others. So that process has been underway since October 7th.
Of course, we don't see everything that happens. He does talk amongst yourselves all the time about this, or?
I don't really think so. I think a lot of people are talking to Stephen, or different people talk to different people. I think Michelle mentioned that, she was talking to some other people on this proposal that they made.
Anytime.
Which, and I don't know who talks to who and when they talk to them, but we haven't had like organized